Stephen has been wonderfully hospitable to my wife and I just wanted you to know that we appreciate that, and it's a real pleasure to be here. So as you can see, I work at the University of Auckland, Department of General Practice and Primary Health Care, and I'm Deputy Head of Department. And the topic for this presentation is, how does person-centered care differ from patient-centered? That's my question that I'm trying to address. And I know there we go. So New Zealand, whoops, there's a slight delay, I think, and there we go. Have I got, is there a, no, it's not working. I'm sure you're familiar with the fact that New Zealand is at the bottom of the world, and so there we are down there, and 4 million people, 60 million sheep, and we get teased about that a lot. This is Auckland, the city of sails in the summertime, beautiful city. We would love you to come. And this is where I work in the School of Population Health at the University of Auckland. Okay. So basically I want to suggest to you that medicine is undergoing a crisis of depersonalization. I've quoted there Andrew Miles, who was the editor-in-chief of the Journal of Evaluation and Clinical Practice. Andrew refers to, quote, a crisis within medicine, a crisis of knowledge, compassion, care and cost, which I think is a very nice way to just put succinctly the state of healthcare at the present time. It's become more managerial and scientific. This probably won't be unfamiliar to you. Depersonalizing clinicians and their patients and their informal caregivers. And increasingly, as you know, we have aging populations, people living ever longer with disability, frailty, etc. Now, some health systems, and I think the US is probably the kind of epitome of this, is they have responded by trying to revitalise patient-centred care. And I want to suggest to you that actually patient-centred care is part of the problem, and what we really need to be doing is moving toward person-centred care. So really I want to address two questions. First of all, let's start by defining patient-centered medicine or patient-centered care. There's a delay, which is, okay. I want to define patient-centered medicine, patient-centered care, what is it? And then look at person-centered medicine and how might that, at least from my perspective, be different from patient-centered medicine. So what is patient-centered medicine? Well, as Sandra Tannenbaum has pointed out, the meaning of patient-centered care, patient-centered medicine is contested. People disagree sometimes on exactly what it refers to. The meaning is obscure. And even the term patient is problematic because it tends to connote the acquired vulnerability of someone who has been acted upon in patiently receiving medical care or health care. What is patient-centered medicine not appropriately described as? I put this in because I was really responding to Andrew Miles and saying to him, trying to say respectfully that I disagreed with him, because in the journal, as Stephen may know, Andrew has referred to patient-centered care being a patient-directed consumerist form of care, and I think that actually that's being unfair to patient-centered medicine. I don't think that's true at all, because actually if you look at what the protagonists of patient-centered medicine have said, they have stated, quote, that patients' wishes do not direct care, patients' wishes merely guide clinical decision-making. And as Honora O'Neill, who's a British ethicist of great repute, has pointed out, actually patient autonomy is very much an illusion, because at most patients can merely accept or reject the care that is offered to them by their clinician. So what is patient-centered care, patient-centered medicine? You might be familiar with Don Berwick in the States, big name, an advisor to President Obama, I believe, now. And in a paper that he published in Medical Care, he identified the top 3 as characteristics of patient-centered medicine. The first one is simply that the needs of the patient come first. We're here to help patients. And that is given a fancy name, which is in the Physician Charter, it's described as the principle of primacy of patient welfare. And the second principle is nothing about me without me, which is Don's fancy way of really saying that patient-centered medicine emphasises the full participation of the patient. Sorry, I keep walking in front of you. I apologise about that. And the third point, every patient is the only patient, emphasising the importance of individualised care. And I've added a fourth one, all people are patients. I think we've reached a sort of point in our history where increasingly, whether you're sick or not, you're viewed as a patient and are required or expected to undergo a raft of different forms of care, screening, immunisation, etc., not only for the sick, but for those who are at risk of being sick. Now, this is an image of a lithograph produced by the Norwegian artist Everard Munch, and it's called Jealousy. It was produced in 1896, and I don't want to talk about jealousy, but what I do want to do is use his image as a visual metaphor for showing you how I perceive patient-centered care. So this chap in the front is the doctor, and the couple behind him, for me, are the patients. What's important for me when I see this is the juxtaposition of dark and light, shadow and light, because the doctor, or it could be the clinician, is in the dark. The patients are in the light. The spotlight is on the patients, right? Putting the patient's needs first. Now, think about this carefully. The doctor, sight, seeing, is a visual metaphor for care. The doctor can see the patients. The doctor cares about the patients. Of course the doctor cares about the patients. But the doctor's in the dark, so he can't see himself. And we know that doctors neglect their own healthcare needs, with problems with compassion fatigue and burnout. So that's a real problem, doctors neglecting their own health. The doctor can't see himself, can't self-care. The patients can see themselves because they're in the light, and that's part of patient-centered care, chronic disease self-management, looking after yourself as part of a package, a partnership with the clinician. But the doctor's in the dark, so they can't really see the doctor, i.e. they're not particularly interested in caring about the doctor. They're caring about themselves, and they want the doctor to care about them. So to me, this image symbolises quite nicely patient-centered care. Now, I think it's a fundamental problem with this principle of primacy of patient welfare, of putting the welfare of the patient first. Many of us just take it for granted, but if you really think about it, and many people have, including some very wise individuals, you come up with a number of problems. Some of you may be familiar with Robert Veitch, who's a well-known ethicist. He describes this principle as controversial at best, morally offensive at worst. Renan Gillen, who was the editor of the Journal of Medical Ethics, in 1986 wrote, if I can find the quote for you, let me just find that quote because it's a nice quote and I haven't committed it to memory. So he wrote 30 years ago, if the profession really believed that the patient's interests always come first, then presumably it would not allow medical time and effort to be diverted away from direct therapeutic activity. Now, here is another Munch image, which I'm using to illustrate some of the points that population healthcare that David Wendler has been writing about. If you go to the Journal of Medical Ethics again, and his name is Wendler, David Wendler, he's an American chap, really, really nice paper. What he's done in that paper is describe 26 exceptions to the principle of primacy of patient welfare. Really good. Worth reading that paper, 3 or 4 pages long. Highly recommend it to you. let's move on, because I know that I think we want to make the most of the opportunity for discussion, so I have to be careful. Basically, I'm saying that that patient-centered care has a weak track record. It's actually stood by and watched while evidence-based medicine has achieved notoriety, for want of a better word. What has held EBM to account is not so much protagonists or proponents of patient-centered care, but I think the people that I've been working with, Andrew, in the Journal of Evaluation and Clinical Practice, Andrew Miles, Ross Upshaw, Michael Laughlin, me, Mark Tonelli, and others. And actually, if you look in the Cochrane reviews, there are 2 Cochrane reviews that show that patient-centered medicine has actually had quite mixed effects. So, I'm not convinced that it actually works. And let's move on. Okay, so for such reasons, there has been growing interest among many of us in developing a new model, and you might be thinking, oh no, not another set of terms, because there are already so many: relationship-centered care and whole person care, etc. The WHO has, let me restate that, person-centered care has the imprimatur of the World Health Organization. They call it people-centered care. The World Medical Association, World Psychiatry Association, WONCA, they've all got behind person-centered, people-centered care. But what actually is people-centered care? And I'm not sure we actually agree with it. We're talking past each other. And so I think one of the things I need to do in my book is offer my own perspective. Conceptually, what is it? Let's actually unpack this term and see if we can think about what its philosophical roots are. I think that one of the problems is that sometimes people use the language of person-centered, but they're still talking about patient-centered care. They're actually just redressing, and I've deliberately hyphenated it because they're dressing up again patient-centered care in new clothes, but the clothes are empty. The emperor has no clothes. And I was in Sweden, lovely, lovely people, but in the centre in Gothenburg, I left thinking, they call it person-centered, but it seems to me very much patient-centered. So I'm going to clarify in a moment what I think the differences are. I don't need to say much about this. American physician Francis Peabody, Paul Tournier, a Swiss family physician, the Balins, Michael and Enid Balint. These individuals at the top, the 2 gentlemen, are often described as being progenitors of a person-centered. I actually think they have more to do with patient-centered, and the Balin's actually originally described their model as person-centered, and I think it's got many of the attributes of person-centered care. Okay. So what is person-centered care? This is my definition. It's a humanist virtue ethics. A humanist virtue ethics, a value-strong ethics of virtue that brings together the sciences and the humanities in order not only to promote health and well-being, but to actually nourish the personhood of doctors or clinicians and patients as moral equals. It's not just about health and well-being, but about self-actualization and flourishing, eudaimonia, Aristotelian flourishing. So there have been people writing about values-based medicine, and I'm trying to suggest that those values sprout virtues. So medicine is rooted in values from which emerge spontaneously these emergent virtues. What do I mean by values and virtues? Values I'm defining as our fundamental and freely held beliefs about what is important. By virtues, I basically mean stable, robust dispositions of good character that predispose us habitually to do the right thing for the right reasons at the right time. Okay, it's about being a being, ontologically being a good person, which will dispose us naturally, habitually, without having to make a special effort to behave in a good way, to be put towards ourselves and other people. And so basically, I'm defining a person existentially as all human beings. Okay, that way you avoid all the problems about which set of criteria or properties do you use, consciousness, rationality, memory, etc., that different philosophers have debated about. So all human beings, but we need to look at who is the person as well, relationally, and in terms of the capabilities that we can help them manifest and actualize. Okay, now this is the key slide. This is the main slide I want to show to you. What I want to suggest is that we've got person-centered, It doesn't really work. Person-centered medicine and patient-centered medicine have some values that are different. There'll be others that aren't there, like compassion, that will be common to both. And then these values of person-centered medicine give rise to particular virtues, and I've given you some examples, but it's not exhaustive. So the first value is itself virtue. I'm going to suggest to you that person-centered medicine is a virtue ethic, whereas patient-centered medicine is a duty-based ethic. I'll elaborate on each of these in turn, so we'll go through the whole lot. So virtue versus duty. So person-centered medicine is about using the virtue of phronesis or prudence or practical wisdom, if you like, which draws on the intuition, etc. I'll talk a bit more about that later, to make sure that people do the right things for the right reasons in their particular situation. So it's quite particularistic and situational. This is here less interested in the reasons, but more about actually doing it because it's your responsibility in terms of patient-centered medicine. It's principle governed, as in the position charter. Personalism versus role theory. So person-centered medicine puts the person first, above divisions based on role and functionality. Whereas patient-centered medicine focuses on the patient and is sort of role-based. The roles of patient and clinician are themselves totalizing and hegemonic. And the personhood is implicit but secondary to those social roles. The third one is critical. The third one is saying that person-centered medicine emphasizes the moral equality of the doctor/clinician and the patient on the basis of the fact that they are both human persons. Whereas person-centered medicine actually puts the welfare of the patient first. Remember, principle of primacy of patient welfare. So this is saying, actually, I don't want to take the spotlight off the patient. That's not what I'm saying. What I want to do is make the light bigger to embrace the clinician, because we're all moral equals. The doctor's as a person too. The informal caregiver is a person. The practice manager is a person. The patient is a person. And they're all people are important. And this is not about removing care from the patient. I wanted to give you a couple of examples of what I mean by moral equality. So the first one is reciprocated care. The care is not just clinician to patient. It's actually reciprocal in the sense of these four directions of caregiving. Doctor cares about patient, doctor cares about self, patient cares about self, and patient cares about the doctor. To the extent that the patient is capable, because I know what people think, and they're absolutely right. Many patients are incredibly vulnerable and in very little shape to care, but it might just be something as simple as thank you, or I like your new glasses, or something like that. And interestingly, one of the people I found who have been most supportive of what I've done are the last people you might expect. They're the palliative care doctors. I mentioned Rod McLeod to you yesterday. He's a palliative care physician, and he really likes my window mirror model, which I produced with Glenn Elwyn. I'll explain it to you very, very briefly. Basically, if you are in your living room at night and it's light inside and dark outside, what you see in the window is your reflection. And if it's dark inside and light outside in the courtyard, you can see through the window. But if the light is of equal intensity on both sides of the window pane, you get a window mirror effect. Okay, it's a form of symmetrical balancing. Let me go a bit more quickly. Another example is mutual trust, based on not only moral agency, but also the authenticity of the participants in the clinical interaction, vis-a-vis patient-centered medicine that is very sort of much focused on respect for patient autonomy. This here, what I'm trying to do here is actually say that person-centered medicine goes beyond a focus on health and welfare and well-being. It's almost a celebration of life. through this term joyful caring that Patch Adams talks about, which I really like, and it's sort of through caring, through appropriate humour, through self-transcendence, through spirituality, connectedness, all those sorts of things. And this is about authenticity versus emotion management. The key point here is that in patient-centered care, sometimes, as in JAMA, you will read about the importance of emotional labour, which includes surface acting as well as deep acting. And to put it really, really simply, it means faking it if you have to. And I've said to people at work, do you really want your doctor to fake compassion? And the response uniformly is, no, I don't. So I would prefer too that my doctor, that she be, and I believe she is, true to herself, not to the point of, being inappropriately truth-telling, but being genuine and sincere and caring for the right reasons. And last point here really is saying that EBM is very much focused on research evidence, although it has changed over time. There have been serial reconstitutions of evidence-based medicine since the early 90s, and even before then, David Eadie with clinical guidelines. Patient-centered care has focused very much on the care part, weak on the science. I think what we need to do is actually bring all these together because they're all important. Science is important, care is important. And so it's quite an integrative approach that tries to bridge together science and humanism, the faith-based traditions, moral interests, virtue, personal care and population health care. My aim is to be very integrative and inclusive rather than focus merely on service to patients. What I'm trying to do here, I won't say much about it other than whilst my window mirror model is nicely aspirational in its approach or in its depiction of balanced balancing that is symmetrical, what I'm actually showing here using art is asymmetrical balancing, because I think what I'm trying to do here is actually acknowledge the reality that there is asymmetry of power between the clinician and the patient, and in that context we need to try to achieve balancing. And this is a painting by an American painter, Mary Cassatt. It's often used in art textbooks to show asymmetrical balancing, but I won't go into the detail. And then how do we move forward? Again, it's a whole topic in itself, but I think we need these sorts of steps. We need dialogue where we're not trying to persuade each other just to share information and understand where each other's coming from, because for too often we just talk past each other and whack each other over the head. It's not constructive, it's not helpful, it's not the way to move forward. Deliberation, where you move toward advocacy and persuasion if you can. And then practical judgment, phronesis, virtue-based analytic reasoning. But I'm really keen on intuition. I think we mustn't forget intuition. And there have been some nice books about appropriate intuition. I published a paper in the Journal of General and Internal Medicine about when patient intuition is appropriate. Because it's often disparaged, because it's prone to all kinds of biases. I mean, we have to take those on board, but at the same time, patient intuition is also a resource that can be used appropriately. And that's my quick talk. Okay, thank you.
So I was, you're using a virtue-based approach. I'm partial to that, so I'm really behind what you're trying to get at. I was really surprised at your comment disparaging a patient who would fake compassion, because there may be some extent to which you're not feeling it right now, but the way that you inculcate the authentic disposition to act compassionately is to go through the motions until it becomes sort of second nature to you. In that way, you are more disposed to do it authentically rather than giving into impulses to be sort of snippy.
I think what happens is that, as Aristotle said, the virtues become embedded through practice. I accept that. So initially there is some effort required. But I understand that. I seem to have some antibodies toward faking a clinician faking compassion, and I'm not sure I've yet resolved the tension, how to bring the two together. It's a good point. The whole performative nature of care, is that something that we want to promote? You know, acting. What do you think? I'm not sure I have the answers actually. Yeah.
If I'm getting it right, I'm thinking that one of the things that we teach in medical school is the self-awareness section.
Yeah.
And I think that if students, for example, experience the practice of self-awareness, that over time the idea of compassion can be, in a sense, acted at first.
Yeah.
Because then they begin to internalize some of the principles and the virtue and the other things that come along with being aware of their prejudices or their negative thoughts. And once they're aware of them, they can place them aside and perhaps advocate for a patient or feel more compassion for the patient and exercise, you know, the things that are considered duty, but in a more compassionate way because they recognize that these are prejudices that they have. Is that
I'm just
clear,
not sure.
I mean, it's still acting, but maybe over time, if they recognize what their baggage is.
I'm just not sure that, and I'm happy, as I say, I'm happy to discuss it and debate because I don't know the right, but I'm just not convinced yet that inauthenticity is a necessary precursor to authenticity.
Oh, I don't think it's necessary.
No,
I'm saying that if it exists, then being aware of it.
Yeah, well, we should be aware.
Overcome it.
Yes, exactly. But I think, Michael, were you suggesting that we need to act as a starting point, and then, and I'm not sure that whether that's desirable or not, I don't know.
Yeah, I mean, you can have, so you said the virtues sort of spring naturally from values. So if the idea is I don't necessarily feel this sense of compassion right now, but I know that I value the patient, then I will act sort of on an intellectual understanding of the value in a compassionate way, but it's not motivated by the same thing that you're sort of describing yet.
Yeah, I think what you're saying is interesting because what you're doing implicitly, for me at least, is you're making a distinction between cognitive empathy and affective. So a starting point might be that by cognitive empathy, I mean that I simply understand this or your perspective, or I think I can imagine what your perspective. Yeah, what it feels like to be in your situation. Actually, I shouldn't have said feel because that starts to move into affective. But it's more of a mental understanding vis-a-vis feeling affectively. So maybe the cognitive is the first step, and then the affective, and then the behavioural manifestation of that and showing empathy.
I'm not sure that this stays on the ground.
Okay.
Yeah. That sort of clarity. So, to me, but correct me, if I'm wrong. The key issue here is that everything is patient-centered, and you see the banners out along the walls to that effect.
Yeah.
And it really is not working because many of the people on staff, nurses, clinicians, and others, are not adequately encouraged to care for themselves.
Yeah.
And this can't go on forever, so you have increasing rates of burnout, depression, and suicide.
That's right.
In the last 5 or 6 years, 10 years.
Yeah.
On the part of the healthcare team, professionals. So what this model suggests, although again, person-centered is a language game, I don't know, but it's basically saying we're talking about equal moral considerability, equal moral consideration of everybody involved.
Yes.
So it's not just this almost, what should I say, self-immolating commitment to the patient's good. But it's a real reflection on balance, for example, in caregivers. So, medi in medicine coming from the same word, medi meaning balance. It means that the care of the self as a caregiver is just as important as professional beneficence and so forth. So here in the institution, we're doing now Schwartz rounds. The first one is at the end of July, where clinicians can come together and really talk about their internal struggles with certain clinical cases that have been very, very difficult for them on a deep gut level that they've been losing a lot of sleep over. We're doing reflection rounds across the clerkship so medical students can step out from their skill set learning for an hour every couple of weeks and just talk about the things that are bothering them most, that they've experienced that are really on their minds in a deep and effective way. And we're talking about other kinds of approaches, but basically to take the care of the caregiver much more into account. And that also includes, as you were pointing out, a certain sense of patient responsibility or patient virtue. So not that you can ever depend entirely on a statement of gratitude. I guess you would be naive.
Yeah.
But even the simple things, that patients are coming into this, not simply, looking for their next legal suit or looking for how they can possibly manipulate the situation one way or another, not to someone, but that they're really taking the idea that which I do, whenever I need to be with a doctor or a situation as a patient, I'm always kind of looking at them for the doctor, and I'm kind of being empathetic toward them, measuring their situation, trying to say things that are supportive for them. So it's a relational kind of a thing, and I'm not sure we have the right word for it.
Sure.
But it is important because I don't think the institutions are doing enough to look after. They're looking after patients, patient-centered, but we also be doing more deliberate activities for those who are delivering care.
Can I just add one? Absolutely, very helpful. Thank you, Stephen. I just want to add one thing to it, which you might find helpful, which is to describe briefly how I became interested in this. And it was finding a counterpoint to this principle of primacy of patient welfare. And that counterpoint was Peter Singer's work. Peter Singer is an applied ethicist, Australian-based, originally then moved to Princeton. And he talks about, well, it's not his principle, but he revitalized it, the principle of equal consideration of equal interests. Have you heard of that? And it comes from, he's applied it to vegetarianism. So he says that, animals are sentient beings and they experience pain and we need to consider their interests equally. And I was quite interested in that. But it's a preference utilitarian approach, and when I got into it, I found the virtue approach more personally attractive, and so I kind of shifted away from him, but I was very much influenced by by the egalitarian form of what he was advocating that appealed to me, that we're all moral equals. I really like that. So that is a big difference between patient-centered, which is centering on the patient, versus everybody and being inclusive. So,
just to respond to that, I understand that it's patient-centered model, that it's just we teach the doctors that your job is to focus on the patients and not everything.
Yeah.
So if we went about to change the model then to person-centered, I understand that it would be easier than to just go and change the curriculum almost in a sense. But then how do you change, because now it's not just about the doctor, it's about the patient also understanding the doctor, the nurses, and everybody who's a part of the system.
Yeah.
How do we go about educating that side?
Okay, so two-pronged approach. I think that beyond medical education, which needs to become more virtue-based, and actually I've been in England and in Birmingham, there's now the Jubilee Centre for Character and Virtue, and they talk about changes in education to make it more character-based. I think doctors can enable patients through modelling and coaching to develop some virtues, but I think the truth is that actually, and this is where I upset some people in London because they thought that what I was arguing for was really revolutionary, and in a sense it is. I think there has to be fundamental structural change in society. It's not just enough to, where basically we need to create, this is aspirational and idealistic, but a world in which we actually, I love Stephen's work on unlimited love, that we actually care for one another and for ourselves. It's not just healthcare, it has to be permeate the society. And so one of the interesting areas is like, we are living in a world where technology is advancing rapidly. How do we recognize and obtain the benefits that that technology offers, but do so in a way that is not objectifying and depersonalizing and marry them together? Yeah. So fundamental social change is really my answer to you.
I think it includes, by the way, this idea of caring for everybody. It includes self-care on the part of the patient.
Yeah.
20% of every dollar goes toward non-adherence, non-self-care. It's a big waste of money.
Yep.
It's incredibly frustrating for the caregivers. I have had medical students break out in tears. A couple of months ago, there was one in one of these reflection hours who said, "I'm paying all this money. I'm going into debt. I'm working so hard night and day, and I've got these patients, in this case, some diabetic patients, and they just don't give a damn about themselves." And the guy started crying. This was about 7 or 8 years. And he said, "What am I doing this for?" And so it's that level of frustration that that you can bring out and let people process, which is good for them long term. But it's also a comment on how patients. Of course, they have their autonomy, but they need to be reasonably self-caring as part of the reciprocal model.
I really like that, and I think in order to self-care, you need to know yourself, and in order to know yourself, you need to reflect in a quiet space. I love all those books about walking. We've got a park over the road. Every day I try to go for a walk, because that's part of getting to know myself and being with myself and having some space.
This is actually a question. Your talk is very interesting. I'm wondering to what extent you think this idea is more likely to succeed in countries unlike the United States who have a national health insurance. Because so much of medical stress on our providers is provided by adhering to this commercial system.
Yeah.
It's never been able to get enough people together to say we value the health of all of our people.
Yeah.
It's something that's, when I spent time in New Zealand, people always ask me, how can you do this? Why do Americans do this?
Yeah.
And it strikes me that our system exacerbates the problem of person.
Yeah. Yeah, I agree with you, and I am skeptical that the US will change. Numerous presidents have tried. Clinton tried, and Obama has tried with Obamacare, and has a very watered-down version, I think, of what he wanted. And it's really sad that you don't have a national health. What we have in New Zealand is a mixed capitation fee-for-service system. So, I'm kind of registered with a practice, and when I go and see my doctor, I pay her about $25 American, and I get 20 minutes quality time with her, and there's longitudinal care. And Michael and I were talking earlier, she's a gatekeeper to the specialist consultants. It's a shame. I don't know what to say. It requires fundamental political change. Yeah. Yeah, it's really sad, isn't it, that the US has these, huge inequalities. Yeah.
I think that in terms of this reciprocal model, part of the burden on healthcare providers is that they have lots of quote-unquote difficult patients. Sometimes it's a difficult relationship, and oftentimes the patient is difficult because he or she has had to game the most miserable system, and they're more stressed out not so much by having a serious illness, but by all the damn paperwork, and of course that's that's a stress on the doctors too.
Sure.
But it's so easy to become non-virtuous as a patient when you're grappling with all this garbled.
Good point.
And it is stressful, and it does create negative emotions and stress. So I think that in that sense, the system itself breeds this sort of adversarial and acrimonious relationality, which is not good for the caregivers.
Yeah, absolutely. Totally endorse that.
One of the things I really liked in your talk was when you said that when we talk about this stuff, it actually involves 4 relationships, not just the patient, the physician to the patient, but the physician to themselves, the patient to themselves. So much of medical ethics sort of narrowly focuses on the very brief physician-patient encounter, and there's so much more to medical care that takes place outside of that, including all of self-care. I think that's a really nice.
The danger is, and this is not what I'm suggesting, but the danger is that we somehow diminish the focus on the patient, because we mustn't do that. The patient is really vulnerable and in need, but physicians also have needs, and they're people, and as we know, burnout, suicide, all kinds of mental health problems. We need to look after our doctors, A, because they are people in their own right, and also B, because if my doctor's in poor shape, she's in no condition to help me. So,
Well, we had that incident before. I was thinking of prevention care, caregivers, family caregivers, depression caregivers, were caring for these persons that they constantly hear that they need to care for themselves because they don't take care of themselves.
yeah. Okay.
It's fascinating. I mean, my own personal experience. As I worked for many years as a hospitalist here, and for me personally, I did it for years, and I really reached total burnout. Yeah. So, and I did feel that in the patient-centered care model, the patients would go to our patient advocacy office. They would come at me and, sort of attack me, protecting the patient always. And I felt very, undercared for, underrecognized, my own needs. And over time, it just, after years of doing it, I thought I can't. So I left, actually, and ended up doing administrative work. And it took me a while, but I'm moving back into patient care again. And I just want to try to prepare myself for a way to do it that's more balanced and that I feel a little more nourished, because I just really couldn't sustain it and sustain my family. So I'm hoping, that's really why I'm here, actually. After a few years of doing a little bit of patient care before administrative work, I'm kind of trying to prepare myself to move back, and I'm focusing on obesity medicine, which is an interest of mine, and weight loss. And I'm interested in also how to get the patients motivated to be involved in their self-care. So, hoping to come with a different philosophy and focus.
But the whole structure being so patient-oriented, patient advocacy, patient perspective.
It's just.
And in the meanwhile, you're imploding.
Yeah, I felt I imploded at some point after years of doing that. And I see, if you look at any of the people doing inpatient work, or any of the physicians, they can't maintain it. They're constantly under attack by the patients, by the institution, by everybody. So it's tough.
Another problem that's an interprofessional issue too is that nurse-to-patient ratios are dramatically changing now. Nurses are fewer and fewer on the floors, so they are less able to mediate between physicians and the patients. Try to add some humanity to the patient's experience that way. That adds another aspect of conflict too.
I think, just a final comment, one of the hurdles that people like me need to jump is the language around virtue ethics, because virtue is slightly off-putting, sort of sounds saintly. People say, oh, that's unrealistic, but it's actually, I'm very much with Aristotle on the golden mean, and Confucius and Taoism and so on, where it's not about the extremes of Kantian truth telling all the time, and versus being a liar. It's a nice middle ground. Not scaremongering, but being sincere and authentic. So I don't think we're asking people to be angelic or saints or something. Just to be the best people they can be.
Thank you.